So you've asked me to speak about stimulation protocol for endometriosis in IVF. Yes, we were debating when IVF should be done, and I could see some of the questions coming in, whether IVF should be done in patients of with endometriosis and when it should be done. Should it be different from other people? Again, it's a decision that you take on the couple basis. Mostly after 2 years of trying, we say that IVF will give you chances over and above your natural chances. So you make the decision for IVF when the chances with IVF are higher than the natural chances. You do reduce the duration. If the age is higher, then obviously you have to individualize the couples. So my presentation starts with once you've made the decision for IVF, which stimulation protocols you use. So the aim of ovarian stimulation in IVF is you get appropriate number of eggs, which are mature. No ovarian hyperstimulation, because we want to provide the treatment, which is very safe. Endometrial receptivity is not affected by us giving ovarian stimulation. We all know, and we've just heard brilliant lecture from Professor Lissy about endometrium and how important it is. So whatever ovarian stimulation we are giving should not really negatively affect endometrial receptivity. And if there is endometrioma present, then that should not get further increase in size or not worsen beyond a certain limit. And same as if there are endometriosis symptoms, by giving ovarian stimulation, it should not get worsen. So these are the aims for ovarian stimulation in general anyway. But the question is, should we be having different protocols in endometriosis patients compared to non-endometriosis patients? Well, they are slightly different because there is a risk of endometriosis, which can increase in severity because endometriosis thrives on estrogen, it feeds on estrogen. And by ovarian stimulation, we are increasing the estrogen in the body, and so is the endometriosis is going to increase. As already mentioned, that endometrioma may increase in size, and that is one of the reasons why people who operate on it, and I know there is debate in the evidence whether we should operate or we should not operate, and more evidence is moving towards we should not operate. But endometrioma does increase in size, and if you are repeatedly doing IVF 1, 2, 3 cycle one after another, the endometrioma, you'll be surprised, sometimes double in size by the time you reach second or third cycle. There is also some evidence that fewer oocytes are retrieved in those who have got endometrioma or severe endometriosis. And again, I'm not a basic scientist, but there are kinins and lots of other factors get released, which may have impact on the oocyte quality as well. And there is also some evidence from the observational studies that we have higher cancellation rate because when we give the same dose, women with endometriosis do not respond so well. But again, the problem with all these evidence is that endometriosis is very poorly recorded in any of the large registries. I'll give you even example of HFEA registry, which is in UK. Every single treatment of IVF which is done in UK is reported in that registry. We do register the cause of infertility. All it registers is endometriosis, but it doesn't register any severity, whether there's endometrioma or not. So that is why, and that is similar in other registries as well, and that is why this evidence is mostly extrapolated. So we have to take them with a pinch of salt. Ideally, to give you answer which stimulation regimes is best and which type of endometriosis, my dream is that we have this top level of evidence, which is meta-analysis and individual patient data meta-analysis of a randomized controlled trials. Unfortunately, one doesn't exist. When we talk about randomized controlled trials, again, as I go through my presentation, we see how much evidence it is. So ideally, we would like to have these things, but in reality, we don't have these things because Although 50% of patients in infertility clinics, and it's been reported in some studies as high as 50%, have got endometriosis, but minimal mild endometriosis, really, you don't need to have any different protocols. And whether you change the protocols in those ones and whether that make the effect, those kind of studies really don't exist in such a large number and with the right size. So we have to actually go back and rely on cohort studies and case control studies. So although it is a dream, but reality is very different in terms of level of evidence for these things. So when we try to look at the level of evidence, we first need to look at, are all endometriosis the same? As I mentioned to you, even in HFE registry, we only mentioned endometriosis. Minimal mild endometriosis probably doesn't make much difference, and there is controversy. And I know there are some old trials which say if you treat them, you get to spontaneous pregnancy, but they don't answer the question about stimulation regime in IVF. Then you have moderate endometriosis and then severe endometriosis. Now, these three are different categories. You can't just combine them in one category and give an answer similarly. They are completely different. So let's look at what evidence is available right now. So we go through the Cochrane library where we have meta-analysis, which is not individual patient data meta-analysis, but meta-analysis pool data of randomized trial. Now this review of long-term pituitary downregulation, which is like 3 to 6 months of downregulation before IVF in women with endometriosis. This is way back from 2006. Now, if you look at the level of evidence we have got, it is based on 35 cases in the intervention group and 32 in the control group. Now, this is really small number to know the difference between any kind of stimulation regime. And that is very well reflected, although it says that it favors GnRH agonist, but you see the diamond, it is so wide, it is stretched out. This doesn't give you any confidence in the evidence here because it ranges from 1 to 78. And plus this is very old. You're talking about 14-year-old. IVF have changed over the years so much. But this is the only study that reports live birth, which is kind of the gold standard outcome that we should be reporting. We go back a wee bit and see if they report clinical pregnancy rate. So we have slightly better evidence here. There are 3 studies who have reported, but again, if you look at these numbers, when you want to increase 10% pregnancy rate from 30 to 40%, you're looking at, you need at least 700, 800 women. But here we've got 1/10, so 88 and 77. Again, although the diamond is not that stretched out as it was in the previous graph, it is still quite low number, and any big trial coming in can easily change the evidence. But
Dr.
they are,
Abha,
yeah.
Please, can we set the mic close to your mouse, please, to make the voice raise
Okay,
up?
can you hear me now?
Yes, it's clear, more clear. Thank you.
Okay, sorry.
Never mind.
Just raise it a little bit.
Okay, is that okay now?
Yes.
Yes, it is okay. It is okay. From the start.
Okay. Do you want me to do it from the start or you're okay now?
No, you're fine. You're fine.
Okay. So apologies for that. So this is, again, we are talking about clinical pregnancy rate, 3 trials combined together, different populations. But if you look at these years, they are way back from 1992, 2002, again, very old trials. Although there's some evidence that GnRH agonist or long pituitary downregulation is better prior to starting IVF than compared to no pituitary downregulation. So some evidence is there, but as I've said to you, very limited. So again, we take it with a pinch of salt when we are using it in clinical practice today. So there are controversies, and I could see some of the questions coming in the QA. Pre-stimulation, do we give GnRH agonist or should we give oral contraceptive pills? because they both do the same job. GnRH agonist obviously has the disadvantage of menopausal side effects. Most of these patients, if they were symptomatic, they were already on pill. Can we use that pill to start the IVF cycle? Well, if they've been on pill, we just start them. If they're on GnRH agonist, then we use that downregulation. But again, to give downregulation, quite long downregulation, somebody with low ovarian reserve, there is controversy. And again, how long do you give them? Do you give them 3 months? Do you give them 6 months? Do you give them a year? Normally, the previous slide I showed you, it is 3 to 6 months. But again, there are further data to suggest that reduced duration will be better. What stimulation kind of drugs do you use? Do you use FSH alone? Do you use FSH or LH? Do you add further adjuvants? Or whether you go use agonist or antagonist? Again, these are the controversies and people have tried to answer them. So let's look at some of the evidence. As I said, the evidence, although we will look at it, but it's limited. So where we come up with is the combination of where clinical judgment is used, because we don't have very many high quality evidence as the top of the evidence pyramid suggests. We look at the scientific data. We also have to value patients' preferences, which is very, very important. And most randomized trials miss that, because unless patient is happy with that, patient is buying into what you're giving them, then it's of no value. So all these three need to combine to give you evidence-based medicine, especially when the evidence is not clear-cut one way or the other. So here's the trial, which shows, and I'm pleased to note that some of the trials have been published. These are the newer ones. So they have compared shortened protocol of pituitary downregulation versus long protocol, like 6 months versus the shorter protocol. So they have done quite large number, 460 and 288, compared to what we had in the meta-analysis previously. Whether you do single or double embryo transfer, the difference wasn't there. Whether implantation rate, clinical pregnancy rate, ectopic pregnancy rate, anything, there is no difference, as you can see from the p-values. So whether you give them for shorter duration, whether you give them for longer duration, there is no difference. So why subject patient for the longer duration? You could argue that this is one cycle, the cumulative live birth may be different, but actually not. If you look at this, for first cycle, there was no difference. Second cycle, there was no difference. And more than 3 cycles, there was no difference again. So if you don't get any benefit other than prolonging the duration of the treatment, other than extra adding injections and increasing the side effect, the long downregulation, when you subject them to randomized trials, it's not showing much difference. And this is much larger data compared to the previous ones available. There is this is again data about if you have endometrioma and prior to IVF, do you give GnRH agonist? This is again a randomized trial, much lower number than the one I just showed you. But this one shows that it doubles the pregnancy rate in group B, where you are giving prolonged agonist downregulation. This needs to be replicated, because when you look at the evidence in IVF, if anything that is doubling the pregnancy rate, you really need much large number, and you need to replicate it, because nothing really doubles the pregnancy rate in IVF to that extent with this just one intervention. So again, other people need to replicate this one with a larger number. There's another RCT to evaluate the influence of adjuvant medical treatment when you have peritoneal endometriosis. Again, as Professor Lees mentioned, the peritoneal endometriosis creates cytokinins and other things, and it affects the implantation and other outcomes in IVF. So here's a trial published in Human Reproduction, and again, a bit more recent. So they have given, again, 3 doses of Zoladex, which is GnRH agonist, whereas here, much smaller duration of these suppression. And let's see what the outcome is. So they have randomized smaller number, but again, much more than the initial meta-analysis showed. So 61 in the intervention group and 59 in the, 59 in the intervention group and 1 in the control group. So again, they are going to find out whether the difference is there or not, but as far as I'm aware, there was no difference either. So what we do in Aberdeen is we assess the ovarian reserve based on antral follicle count, history. We used to do FSH, but we do AMH now. So if anybody is hyper-responders, then we give antagonist protocol. We usually use norethistron just to schedule. And if you've got lots of antral follicles, then we delay the start because we want to dampen it down, which is normally not the case in endometriosis patient, but you'll be surprised in some minimal mild endometriosis, ovarian reserve is very good. If you have normal responders, then we work on BMI. If BMI is high, then we increase the dose, whereas if BMI is low, then we go according to the age, 150, 2 to 5, 300. We never go beyond 300 because there is no evidence. If it's a predicted low responders, then we do give ultra short protocol, which is starting buserelin, which is GnRH agonist for first 3 days, and starting FSH on day 2 of buserelin. It seems to work well in our hands, but we are aware that ultra short protocol may not have more evidence than antagonist protocol, and future we may look to change it. Also, if there is anybody who has got a history of smoking, irregular cycles or short cycles, or family history of early menopause, we do increase the dose as well. In endometriosis, if you have minimal or mild endometriosis, we just do exactly what I showed you in the previous slide, same as non-endometriosis. If it is moderate or severe endometriosis, then we individualize the care very much. If it is endometrioma, if it's small size, then we don't operate. If somebody's got pain, if somebody's got suspicion of malignancy, or the endometrioma is coming in the way to collect the eggs, then we operate. And if we operate, then after surgery, three months, we give, immediately after surgery, we give GnRH agonist and use that for down regulation and straight to IVF using that down regulation for a month or 2 months whenever we can schedule them. If we don't need to operate on people, then we use long protocol. These are the only ones where we use long protocol, and we give just routine long protocol, 14 to 18 days of GnRH agonist. And we usually discuss these cases as part of multidisciplinary team with our endometriosis experts, so we make a joint decision. We also have to be aware about that most of these endometriosis do have adenomyosis as well, and I know Sylvia is going to speak about adenomyosis, but in terms of stimulation, again, there is evidence that with adenomyosis, long protocol work probably better, again, to reduce all the inflammatory markers. I looked at recently, EFRE guidelines got released about ovarian stimulation. And I read the full guidelines to see if they have made any recommendations for endometriosis, but they haven't really made any specific recommendations for endometriosis, which made me think that probably we should be just treating endometriosis patients as other patients. So same as with low responders, you do GnRH antagonist protocol or agonist, I mean, whatever you use in low responders, it doesn't make much difference whether you give 150 or 300. In normal responders, you should be giving antagonist protocol. In high responder, we all give antagonist protocol anyway. When it comes to freezing all or not freezing all, and I know there were some questions about that, we do again, individualize the care depending upon the symptoms, depending upon severity of endometriosis, and depending upon how many embryos are there. If somebody gets old age, only one good quality embryo, I won't be comfortable in freezing just because they have got endometriosis. And we see pregnancies right, left, and center with that. In future, I think there are more trials coming as well, because there are a few protocols published, which I would like to share with you. So this is a trial comparing, again, long-acting GnRH agonist prior to IVF-EXE. So they have published the protocol. So hopefully in future we'll get a bit more answers. And since more trials are going to come, we might be able to get top quality evidence. So what they're going to do is starting GnRH agonist in the short protocol from day 2 and FSH administration soon after this, compared to this other protocol where they're giving 2 GnRH agonist in endometriosis patient and then doing their gonadotrophin stimulation, which is a longer version. So let's see what they come up with. Again, there is another protocol being published which was one of the controversy, that whether you give oral contraceptive versus long-term pituitary desensitization prior to IVF-EXE, again in moderate to severe endometriosis. So they are again going to randomize 165 in both arms, 3 months use of oral contraceptive versus 3 months down regulation. So we'll be looking forward to their results as well. My suggestion would be reading all the literature, and what we have currently now would follow the EFRE guidance that keep it simple, minimal mild endometriosis, treat them exactly the same as rest of the people, and follow this simple chart. It is very simple, nice diagrammatic representation, minimal intervention, antagonist protocol seems to favor all, don't go beyond 300, and monitor just by ultrasound. HCG trigger for most patients unless it's a hyper responder. Fresh embryo transfer, because with freezing, although you could say that with endometriosis, with all the inflammation and effect on endometrium is there are now risks with freezing all embryos, and the risks are coming in picture now. So we have to keep that in mind. Ultimately, we don't just want live birth or a positive pregnancy test. We are talking about having a healthy baby. So these cases, severe endometriosis, moderate endometriosis, have to be individualized depending upon everything else. Don't just have a blanket policy of freeze all. So I'd be happy to answer any questions with that message. Thank you very much again.